Well, hello everyone. This is Dawn Van Dam. I'm the president of 1 Million Solutions in Health, and welcome to today's webinar. We're very excited as we round the corner towards October 1st and have the opportunity to sometimes have great success and sometimes perhaps have not such great success in implementing ICD-10. So we have a terrific solution or combination of solutions here for you today, and really want to help you go right from the chart straight to billing and never think about ICD-10 anymore. So thanks for joining the webinar today. I'm just going to give you a little bit about 1 Million Solutions in Health, introduce the speakers, and then turn it over to them to share their information with you. So if we can just confirm that I'm on slide number 2, that would be great. So our goal is to improve healthcare one solution at a time at 1 Million Solutions in Health, and we really do that by shaping healthcare by sharing solutions. So this is one excellent way that we have to share solutions with everyone. We also hold live events and do publications and other things like that. We talk about 4 fundamental ways we help people connect. We help them learn and share. We share those innovations all around the world, whether you're from academia, government, entrepreneurs, or business. Let us know your great idea, and we'll find a way to share it with our database of over 2 million members in life science and healthcare. And then if you add in patients, we have over 5 million members in 1 Million Solutions in Health. We also have a consortium working with the industry to accelerate the adoption of new technology into usage and implementation. So let me just give you a little bit of background today about the talk, and then I'll introduce the speakers. So with ICD-10 implementation labeled as the biggest nationwide business undertaking in modern history for physicians, it has become excessively important to get this done and get it done the right way. During this webinar, you will hear from 3 leading experts with over 35 years of experience in medical coding, billing, auditing, and electronic health records. Our speakers will provide their perspectives on the challenges that will be faced when transitioning to the new ICD-10 coding system, and how you can overcome those challenges by using an electronic health record system that will seamlessly make the transition for you, from charting straight to billing. This webinar is designed for pediatricians and other primary care physicians that want an electronic health record that will handle the ICD-10 transition seamlessly. So let me tell you a bit about our speakers today. First of all, Kelly Rogers. She's been in the coding, billing, and auditing career field since 2007. After a 16-year career as a head veterinary technician in an American Veterinary Medical Association accredited hospital in Maryland and Durham, North Carolina, Kelly decided to make her move to the coding and billing world. She quickly achieved her Certified Professional Coder, or CPC certification, studying under Marianne Durling, and then obtained her Certified Professional Medical Auditor certification 3 years later and became an auditor. Kelly studied at Wilson College in Chambersburg, Pennsylvania, and Vance Granville Community College. She is interested in music and theater and enjoys working with her coworkers and is active in her church and with her family. Our next speaker will be Tracy Russell. Tracy is a highly accomplished healthcare professional with over 25 years of experience. She has held previous roles as a medical assistant, pediatric office manager, biller, family practice billing manager, electronic health record trainer, and electronic health record product manager. She is a well-sought-after speaker and has been a guest speaker for the past 3 years for MedImmune Synergis's product on billing, coding, and assuring patient compliance. She has also been a guest speaker at many coding seminars throughout the United States. Tracy Russell, is currently a product manager at Excite Health and an integral member of their ICD-10 implementation team. And our third speaker today will be Barry Hyatt. Barry is founder and CEO of Excite Health, which was founded in May 2011. Barry's areas of focus include online marketplaces, consumer internet, and healthcare. Barry is instrumental in developing and marketing global platforms that can reach hundreds of millions of participants that grow more relevant to its users over time. Prior to Excite Health, Barry was previously the CEO of Modern Medical Modalities, which owns and managed multiple outpatient radiology centers. From 1992 till 2003, Barry served as a corporate finance and investment banker, helping entrepreneurs as well as companies with various financing needs that were trying to go public. He has experience in building winning teams, operations, and corporate governance in order to build companies and shareholders' value. Barry received his bachelor's degree in business administration and economics from Hebrew University in Jerusalem, Israel. So with no further ado, I'm going to not go to Q&A, but I am going to tell you that if you do have any questions during the session, please put them into the chat box, and you can send them to me at Dawn Van Dam, or you can send them to 1 Million Solutions in Health, and we'll moderate those and ask the questions of our panelists after their presentations. So we're going to turn to, I think, Kelly first. Yes, Kelly first, and I'm going to pass her the ball and let her take you through her presentation. And as I said, if you do have any questions, just stick them in the chat box. And at the end of the presentation, we'll just ask you to do a quick short survey so we can hear about what you'd like to learn in the future. Thanks, and over to you, Kelly.
Okay, good morning, everyone, and thanks for joining us this morning for this webinar on my presentation is going to be on ICD-10, and I welcome you this morning. So we're just going to start out by stating the obvious. Physicians are frustrated, and they've been frustrated for quite a while, and that is stating the obvious. In a recent physician survey, only 41% of physician practices are trained for the new ICD-10 transition. 57% of healthcare organizations feel that they are currently not on track with ICD-10 readiness. 15% of the physicians have not started preparing for ICD-10 transition, and 94% of the participants anticipate an increase in their denial rate due to the ICD-10 transition. That means only 6% of participants anticipate that their claims are going to be secure. That's really something. So just a little bit of ICD code history. ICD is the International Statistical Classifications of Diseases, for those of you who didn't know that. It's an alphanumeric designation given to every diagnosis, description of symptoms, and cause of death, which of course is attributed to human beings. I don't think veterinarians would like us getting into their billing. Doctors are already frustrated enough. The ICD codes were first developed in France by Dr. Jacques Bertillon, for those of you who did not know, and it is, of course, the classification of causes of death. It was adopted here in the United States in 1898, and it became ICD-1, which was the first version of code numbers, and it's now developed and monitored by the World Health Organization. In the United States, the NCHS, which is part of the CMS, oversees all of the changes and modifications. Of course, wholesale change is now required. Previous major changes came in 1949 to ICD-6, which was the first time that mental disorders were added, and in 1977 to ICD-9, which is the first time that procedure codes were added, and we know this as CM, which means clinical modification. These describe any health challenges a patient has, and these are important as more physicians move to electronic health records. ICD codes are used by the government, as we know, as the health authorities track certain diseases such as influenza, HIV, sepsis, things like that. And ICD codes are also used to describe a cause of death: cardiac failure, respiratory failure, renal failure, etc. So these ICD codes are developed, as we mentioned before, by the World Health Organization in the United States and overseen by the National Center for Health Statistics, which is a part of the CMS. So the code set is set to go into effect on October 1st of 2015, and it has been a long journey getting here. Basically, the last 6 years we've been trying to get here. January of 2009 was the first suggested date that this code set was set to go into effect, and then the government changed the date to October 1st of 2011. And then they moved it again to October 1st of 2013. Then they moved it again to October 1st, 2014, and we were all certain that that was the set-in-stone date. And then, much to our surprise, they moved it again to 2015. And we all really held our breath. We waited to see what would happen early spring of this year. But alas, here we are. We are 1 week out, and it will take effect. Implementation will happen next week, October 1st, 2015. The American Medical Association moved to have the date pushed back so many times due to 5010 implementation, software upgrades, and basically just the large amount of new codes that are rolling out with ICD-10. The existing code set is going from 13,000 codes with ICD-9 to over 68,000 codes with orthopedics seeing the greatest increase in new codes. So if you are an orthopedic physician or an orthopedic coder or biller, you're going to have the biggest impact in your workload. And although the ICD-10 code set is larger and more complex, it really does have the benefit of providing significantly more information. Laterality and procedural approach are the biggest things that you'll notice. And this is where mScribe can really benefit your practice. Let's just take a look at this particular code, S52.501A. This is an unspecified fracture of the lower end right radius, initial encounter, closed fracture. The S52 indicates the category, which is fracture. The 5 indicates the etiology, which is the cause. The 0 indicates the location, which is distal. 1 indicates the laterality, which is the right side. And the A indicates the extension, which means it's initial. If it was a subsequent visit, there would be a D, and if it was a sequela, there would be an S for the extension. An X would be used as a placeholder for some of the codes if it was needed. Now this is really important. Encoder software with built-in crosswalks is going to benefit coders and physicians immensely in the transition from ICD-9 to ICD-10. So if this is something you are not already using or taking advantage of in your practice already, you need to really consider this. The books obviously are going to be extremely beneficial, but Encoder software is going to have that crosswalk, which is going to help you to find the right code. Let's take another look at a different code, moving from ICD-9 to ICD-10. This is another fracture, 810.02, and you can see how it moves the alphanumeric. The S is first, S42.022A. This is a closed fracture of the shaft of the clavicle. It's a displaced fracture shaft of the left clavicle, initial encounter for the closed fracture. And I just want to explain a little bit about the extension code that goes on the end here. So you can see that if it's an initial visit, the placeholder at the end would be an A. If it's an initial encounter with an open fracture, it would have a B. If it's a subsequent encounter for fracture with routine healing, it would have a D. If it's a subsequent encounter for fracture with delayed healing, it would have a G. If it's a subsequent encounter for fracture with non-union, it would have a K. If it's a subsequent encounter for fracture with malunion, it would have a P. And if it was a sequela visit, it would have an S. So that's how those codes would break out. The placeholder X. Addition of dummy placeholder X's is used in certain codes to allow for future expansion and also fill out empty characters when a code contains fewer than 6 characters and a 7th character applies. When placeholder character applies, it must be used in order for the code to be valid. X is not case sensitive, and in this case, T46.1X5A or T46.1X5A, which is the adverse effect of calcium channel blockers, is the initial encounter. T15.02XD or T15.02XD, foreign body in the cornea left eye, subsequent encounter. You can see how the X holds the place there. So at this time, I'm now going to turn the webinar over to Tracy.
Thanks very much, Kelly. We'll just have you pass the ball to Tracy. And in case I don't think I really said this in the intro of the team and the speakers, but the nice thing is what we have is a phenomenal partnership here between Excite Health, which is a fabulous electronic health record, and mScribe, which is a revenue cycle management company, and they brought themselves together to give you an end-to-end solution. So Tracy, it looks like you have the ball. Are you able to share your screen with us and take us through the demo and show us how the two companies together are more powerful and the multiplier factor of how you can help physicians be successful? Over to you, Tracy.
Okay. Actually, this is kind of a joint presentation today. I'm going to have some assistance from our Vice President of Client Services and Product, which is Chris Tompkins as well. So you're getting benefit of his expertise without having seen him on the list. But what we want to talk about is what our EMR did to make this seamless for physicians. The first thing that we wanted to do was to allow them to use the same treatment plans and the same workflows that they have been using for years, because we wanted them to practice medicine and have ICD-10, the functionality of ICD-10, with the additional detail, without the provider actually having to stop and look for things. So we wanted to put it in the workflow. And what we decided to do, since we have to use what is called a SNOMED code for the computerized processing of information, which is mapped back to the ICD-10 code. And there are more SNOMED codes than there are ICD-10 codes, and some of the SNOMED codes have more than one ICD-10 that has to be associated with them. So what we decided to do, instead of having the provider pick ICD-10 codes and then map those to SNOMED codes for the exchange of information, we decided that since the SNOMEDs, which is the systemized nomenclature of medicine, which happens to be computer processable, those terms are much more user-friendly or provider-friendly, physician-friendly than some of the ICD-10s are. So we decided to go with those very descriptive terms for our assessments, and then we would take those assessments and map those to ICD-10 codes. But we also wanted to give the provider the opportunity to edit ICD-10 codes if he didn't want to build the ICD-10 code that was traditionally associated with that SNOMED. So we built a solution where they would just pick assessments that they've always been using. We actually mapped their old treatment plans to the new assessments using an ICD-9 map, so they didn't lose that functionality. And we put in a lot of things like having them pick locations. So if they pick abdominal pain, then it asks them where the abdominal pain is located, so that the provider doesn't have to go looking for the specific location of pain in the search, and he can build a short list and a treatment plan that encompasses all of that. But we did it in such a way that the provider at any time can edit the ICD-10 code that goes with it. That way, his medical record is accurate, and so is his billing. So I'm going to actually turn this over to Chris and let him take you through. He's going to demonstrate, because we're on his computer, he's going to demonstrate the functionality that we built in. So,
Hello, everyone. Yeah, let's just start off by going into a little more detail of what Tracy just talked about the SNOMED codes, the ICD-10, and all the mapping that's done in the background. So I'm just going to take you in here to look and see how these assessments are actually set up and where you can see all these codes and everything she was just talking about. You'll notice on the screen we have a red U and a green M next to some of these assessments. That obviously means that the U means that there's unmanaged, the M means it's a managed code. We update the managed codes. We will keep those updated throughout the changes and any additions to SNOMED and ICD-10. Those are the codes that we will maintain and update. The U's are just user codes that they have created on their own, and they can associate a 10 code with that if they want. But we're going to stick with these managed codes here. Up top, you will see a SNOMED description of this problem. So that's where she was talking about a little more provider-friendly with these descriptions. Right here is the actual SNOMED code. And then up top here, you have the ICD-10 code that it's mapped to, along with the ICD-9 code that is mapped to right below. You'll notice an exclamation point on this ICD-10 code here. What that signifies is that there are multiple ICD-10 codes that are mapped to this one SNOMED code. And based off of selection and things that are done during the encounter, the system will select the appropriate 10 code to bill at that time. And I'll demonstrate that in a little more detail here in a minute. So let me just go see how this is actually set up in the system. You'll notice that, you don't have to pay attention to this very much, but we have that 9 code, the SNOMED code here. And then we have the option to let the provider or the user type in any name that they want to call this. So if they have a short name that they want to name, that name will be searchable. It's not going to go on any reports or anything like that, but it's just an easy way to find some of these assessments if they want to put their own user display name in there. But really what I want to show you is this tab down here that is the ICD-10 billing code. Okay, you notice that I am on acute otitis media with effusion SNOMED assessment up here. And then these are all the 10 codes that are mapped to that one SNOMED assessment. For instance, you notice you have otitis media right ear, left ear, bilateral, and then some recurrent ones, and then unspecified. So based off of some selections during the encounter, the system will calculate the correct billing code to bill out for that day. All right, so that's the basic configuration of these assessments. Now let's go into an actual patient here, and I'm going to be at the point to where I'm the provider and I am ready to diagnose and treat this patient. So I'm just going to come over here to a button called New Sick Diagnosis. It's going to bring me up that same list here, and I will click on this acute otitis media with effusion. Once I click on that, it brings up a location that I have to specify in order for the system to actually select the correct ICD-10 billing code. So I'm going to select right. And then what the system does is it brings me to the treatment plan for that SNOMED-based assessment. But what we have done is we have taken their old treatment plan from the ICD-9 otitis media ICD-9 treatment plan, and we have mapped it back to this new SNOMED assessment. So there's really no change for the provider. He's just picking a new code. He has all the same treatments that he's always had for otitis media. So that's an easy way for them to transition to this. Not much change, but besides picking a new code. So as you can see here on what we call the SOAP screen, you will see this display of acute otitis media with effusion right. That is the SNOMED-based description. And then right below that, you have the ICD-10 description along with the code right after. You can see that based off my selection, the system chose right ear for me right here. So that is the correct code for right ear. Let's go ahead and look in here at the assessment. Here on this screen, I can see all the mappings of SNOMED, the 9 code, and the 10 code as well. But I can also come over here to this Billing ICD-10 tab, And this box right up here are all those map codes that I showed you on the configuration screen earlier. And then the one highlighted is obviously what the system has already selected for me based off of my location that I picked. If I don't like that, I can override from here by unhighlighting this and highlighting another one and then clicking the Submit Override, and that will change the actual code that I want to build out today. So that's a quick way to actually, you know, look through what is mapped to this code and select one that you want to build out. But most of the time, you know, you're just going to say, okay, yep, that's right, and go on and finish with the patient. So it is that easy to select a sick diagnosis. So let's just come to what we call the billing screen here and take a look at this screen. So you notice we have our office procedure here built out, and there's our 10 code hooked up to that procedure code. So maybe I don't like this code and I'm a biller and I want to see the whole tree view, the whole family of the otitis media codes. Well, I can do that by clicking on the actual code here. And what that will do is that will bring me up the tree view, and you can see where I'm at on that tree view right here. You can see the green arrows designate, this is a billable code. The red arrows designate you must get more specific. So those are non-billable codes. And I can easily, you know, select a different code from here if I want by just looking up and down this tree. So if I wanted to change this to something, I can click on that, click OK, and then it's going to say, would I like to replace that? And if I say OK, now that's what I'm billing out today. So I can look down that tree, make sure I have the most specific, the correct code that I want to bill out based off the documentation, and I can bill that out for today. All right, let's go into a well visit and see the workflow here and how some things that get automatically calculated by the system during a well visit. So I am just going to come in here and give them a well diagnosis. This will bring me up to the treatment plan. Oh, I'm sorry, the auto well there is not set up. So let me just pick the actual well. Let me cancel that one. Let me just go in here and pick one. And I'm not quite sure how old this patient is, but 18 months I think it is. Oops, sorry. So it brings me to the treatment plan, then I come here. So you'll notice that I didn't have to select anything on that encounter, but the system figured out for me, based off of some logic here, that I needed to bill out a routine child health examination without abnormal findings. So the actual logic that is in there is saying the system is looking for any sick diagnoses that were diagnosed during this encounter as well. If there are any, then it will bill with abnormal findings. If there are not any, then it will bill without, like it just did. So let's go see how that flips when I bill a sick diagnosis. And we'll also see another location here by picking a different one. So I'm just going to look at abdominal pain here, and if I click, I see the 10 code here, and I see the exclamation point, so I know that there's multiple mappings to this, and I must specify something in order to build the correct code. So if I click on here, you'll notice I'll get some more choices, and I'll have to pick this to drive the billing. So I'm just going to pick lower left side, come in here and say OK. It will bring me to the treatment plan for that. And when I hit finish, you'll notice that this well child ICD-10 code changed to with abnormal findings. So that is something that the system will calculate for you, so you do not have to make this change every time you have a sick visit, a sick diagnosis as well as a well. So that's something that we have done. We've also put in logic in here for recurrence. So for instance, if you you can specify what length of time you want for your recurrence on an assessment. And the system will calculate that. It will look back and say, okay, has he had this assessment in the last whatever time frame you've designated? And if they did, then it will calculate the recurrent billing code. There's also some codes that are driven by results of a test for a hearing screen or something like that. That will also be calculated for you. So once you order the specific hearing screen and you result that, if you resulted it with an abnormal result, then obviously what will bill for that day when you select the ICD-10 code is the actual hearing screen with, you know, abnormal finding or whatever it actually is. I think it's like with hearing loss or something like that. So that's what will be calculated and billed out for that day. So that is some examples of some of the calculations that the system can do and make it easy on you so you're not having to go in here and search for specific, you know, things happening when it can be automatic like it is with our system here. Let's look at this abdominal pain as well. And this abdominal pain is not a great example, but I can just use it. Let's talk about this. So let's come to the screen. I can see what was already picked here, you know, and let's say I needed to bill an additional ICD-10 code along with this R10.32. I know it's not a great example. You wouldn't have to do it in a real-world situation with this actual SNOMED code, but you will have to do it in other situations. So it's real easy to do, and that's done by just clicking on this search screen here, a search button. And what that does is brings me to select an ICD-10 billing code. So this list is the actual, all the ICD-10 codes that are possible. I'm just on my short personal list here. So I just have a few here, but I can look for all of them if I wanted to. So let's say I had to bill an additional 10 code along with this. I can select these. I can click on the, I can see the green check marks over here signifying this is a billable code. I can click on the actual code here to bring up the tree view as I did before, and I can change it on the fly from here if I wanted to. So once I change that and I select it, it comes over here in the selected items, and I click OK. It's now in this selected items, and what I see from this screen is that I'm about to build these two highlighted codes with that one SNOMED assessment. So by doing that, to make this stick, I have to click the Submit Override. It gives me a warning. I say OK, and then it's updated successfully. And when I come back to this screen, you can see that the additional 10 code is billed out with that SNOMED assessment. Let's say, oh wait, I made a mistake. I don't like that. I can quickly come in here and reset to the original. And it takes that away. So those are some of the easy things that you can do to bill additional codes, to make corrections, and things like that. And then, of course, when you're done with the encounter, same billing screen here, same functionality, you know, by clicking on the actual codes to get the tree view, and you can make changes here as a biller as well. Okay, that is our ICD-10 functionality.
That's our solution and how we built it to take you seamlessly from practicing medicine to the billing without a lot of change.
Great. Well, thank you so much to both of you. I'm going to switch it back to, or Tracy, if you can just pass the ball back to Kelly. We will let Kelly give a summary of where you should be thinking about making changes in your practice in order to adapt to the ICD-10 issues. There you go. So just one more slide. Perfect. Thanks, Kelly.
Okay.
Over to you.
Great. So as far as ICD-10 implementation goes, coding departments and medical providers are going to need to do certain things. learning the new coding system, which includes roughly 55,000 codes with which you may not be familiar. Learning the new code books and styles, which are receiving completely new overhauls. Using both the ICD-10 and the ICD-9 simultaneously for a period of roughly 2 years, because some of those workman compensation insurance companies, they're not switching over to ICD-10. They're going to continue on with ICD-9, even though there's a hard push for them to use the new code set. Some of them are going to continue on with ICD-9. So we're going to stay in both code sets for a while. We're going to have to work with office physicians to go over the new documentation requirements. That's going to be a big thing, documentation requirements. We're going to have to really push physicians hard to maintain that high level of documentation that we need so that we can get the high level of code set that we have to have. We have to have a thorough understanding of medical terminology and human anatomy due to the increased specificity of ICD-10. And that's really where mScribe can come in and help you with all of these implementation issues that we're going to see in the next week, the next month, the next 6 months. Billing departments are going to need to be trained in a new set of policies and procedures to prevent lowered productivity. Billing departments are going to need to learn new policies regarding payment reimbursement. And there's going to be a new understanding of the electronic formatting procedures in addition to the new ANSI reporting methods. That's the American Standard Code information interchanges that we're seeing in the clearinghouses. There are combination codes and examples that are going on with ICD-10 code sets now. The expanded use of combination codes, certain conditions and associated common symptoms or manifestations that I was talking about earlier, poisonings and associated external causes. I-25.110, that's atherosclerotic heart disease of native coronary artery with unstable angina pectoris. In ICD-9, this would have been 2 different ICD-9 codes. In ICD-10, this is one code, E11.311, type 2 diabetes mellitus with unspecified diabetic retinopathy with macular edema. In ICD-9, this would have been 3 different codes. In ICD-10, this is one code, T42.3X2S. Poisoning by barbiturates, intentional self-harm, sequela. You can see that 7th extension character, the S, the sequela. This, again, is a combination code. Again, one code in ICD-10, where in ICD-9 this would have been 2, maybe 3. So this is something that we have to pay attention to in our coding departments, and definitely a higher level of documentation so that we can get to that higher code. Physicians, when you're documenting and you're writing up your charts, these are all the factors and the clinical concepts that you need to keep in mind while you're writing up your charts. What type of incident was it? What kind of time factors, temporal factors were involved with the incident? What causality was there? Symptoms, manifestations, what findings do you have? Localization and laterality, those are big ones. Anatomy, what was it associated with? What was the severity? That's a very big one. What was the episode? What is the remission status? What was the history? Morphology. What is the episode complicated by? Is there an external cause? This is where your E-codes come into play. Is there an activity or a place of occurrence? Loss of consciousness? Is there a substance? If you're an OB or a GYN, the number of gestations, the outcome of delivery, and then things we're seeing more and more of, BMI, and something that I don't have noted here is the use of tobacco. We need to see that now on all of the charts. What is the patient's history of tobacco use? So these are all very important documentation things that we have to see in charts today. Something that came out in July that providers, physicians, coders, and even billing departments are talking about is the CMS ICD-10 grace period. CMS did announce in July that there would be a 12-month grace period for all providers. It does allow for flexibility, but what exactly does that mean? And will claims be rejected if wrong codes are selected? And if wrong codes are selected, can codes be resubmitted without penalty? Well, what exactly this means is CMS clarified its statement that during the 12 months after ICD-10 implementation, contractors would not deny claims based solely on the specificity of ICD-10 diagnosis codes if the ICD-10 codes are valid. And basically what that means is as long as the codes are in the correct coding family. So as long as there was an attempt to get the correct ICD-10 code, the claim would not be denied. So basically, CMS is saying if you're making a decent attempt to choose the correct code, we will allow you a second attempt at resubmitting your claim, and we will not deny your claim, and you can resubmit your claims without penalty. Claims will be processed and will not be audited as long as the first 3 characters are from the correct coding family. This does not mean that you can submit claims that do not at least attempt to provide additional specificity when required, and if a submitted code is not recognized by the system as a valid ICD-10 code, it will be rejected. No ICD-9 codes will be received after October 1st, though, so you cannot submit ICD-9 codes after October 1st. The physician can, in such an instant, resubmit the claims with a valid code. So that's what that means. There are a couple websites at the bottom of this slide that you can go to. One is a CMS website. It's specific for ICD-10. You can go there and find information for ICD-10. And the other one does speak to the grace period. So in summary, ICD-10 implementation sounds horribly frightening and difficult on many levels. But in honesty, as long as the documentation is there, finding the proper code should not be that difficult. Education, preparation, proper documentation, and personal implementation on each of our parts is going to make the transition from ICD-9 to ICD-10 easier and really less painful. So at this time, if anyone has any questions, I am happy to answer those. But that does end my...
Great. Well, thank you very much, Kelly. Actually, if you could switch this ball to Barry. Barry's got a few slides just to cover off the integration of the 2 companies and not the integration of 2 companies, but the integration of an offering from both mScribe and Excite Health, and then we'll open it up for questions. Thanks. Over to you, Barry.
Hi, good morning, everybody. I'd like to welcome and thank all the attendees, and also for the great presentation by Kelly and the great demonstration by Tracy and Chris. As you have seen, we have built a solution that is almost identical to the way that our physicians were using their already medical record. We already managed to keep it in the same workflow with the same assessments, and we did it for a reason. So before I'll go forward, I'd like to touch some highlights on Excite Health, the company. The EHR that you saw a very short demonstration focused on ICD-10. It's an award-winning workflow management that was developed by pediatricians. Our platform automates the entire healthcare practice with user-friendly features. All our EHR, practice management, and patient portal, they're all customizable, and they together efficiently feed the billing and the RCM services so we can maximize revenues and lower the costs of the practice. So everybody wants to optimize their time. Everybody wants that to work efficiently, and that's what our system does as a whole. All our screens are workflow-based, and they are configurables. Our assessment and treatments are configurable, and they are configurable to the individual user, whether it will be the provider, the nurse, or any other role in the practice. Evidently, we need to optimize the billing, and as Chris and Tracy have shown, we go to a great length to pretty much create the codes as the physicians goes with the medical record as is charting. As you could see with Excite, EHR and PM, the billing is seamless. The codes are flowing directly to the practice management for 100% accuracy, while we're still enabling the users or the coders to intervene at any point of time and make any changes they may see fit. Currently, we're updating all our clients with the ICD-10 coding. They pretty much already have it. And we have a complete RCM service in our partnerships with MScribe. So balancing your practice is really key. In order to achieve that, we have intuitive charting, like you got a glimpse of it based on assessments and treatment plans. Simultaneous tasking occurs for the office staff. So when one role, if the provider's in a room and prescribe something and the nurse can see it on her screen, and simultaneously she can carry her task without having to come in and get orders. We always deliver the right task for the right person in real time. Balance your life. Everybody likes to balance work with their life. So our office, when we did a survey, what we found that using our system decreases the patient wait, increases patient satisfaction. Physicians felt more in control of the practice because they can configure all their treatments and all their workflow the way they like to practice medicine and the way that it works for their team, their staff, and their office. That enables them to take back control by balancing all the demands of their practices. Best patient care. Because of Excite EHR is a workflow management system and highly configurable to present the right information to the right person at the right time, it makes sure that the physician touches all the treatment, all the points of care that he wanted to do in advance, and he doesn't miss any of this. Each encounter has its own screen and presentations. And by doing all this, you end up having a happy staff and a more productive staff. That the system provides an ease of use is paramount. The office view dashboard makes it all happen. You screen everybody, everyone at the office. They don't have to scream, yell, communicate at each other. They all can look at the screens, and each role can see what tasks they need to carry at what time, and they can carry it simultaneously. And all this has been accomplished because it was developed by pediatricians for pediatricians who understand intimately the workflow of the doctor's office. Now we'll be open for questions.
Great, thanks very much, Barry. And if we can just switch the slides back to me, that would be great. So today we've had great information here from Kelly, Tracy, also from Chris Tompkins, and from Barry. And I'm going to encourage everyone to put any questions in the chat box, but I'll jump in and start asking the questions that we have already. So there's our speakers. So maybe the first question is sort of, it's been interesting to see that the government has implemented one date for everyone to switch over, and that really doesn't allow for a chance to have people practice or try things out or get any experience. So maybe I'll turn this question to Barry or Tracy or Chris. Have you had a chance to kind of have any beta customers or people try out your system and give you any feedback on how it's working?
Yes, we have done the beta. We had a lot of customers using it, and one of the things, the reaction we got immediately is, wow, what's the difference? It looks almost the same, completely. And we got it over and over, and we are at the point where we're installing all the production. We're finishing installing the production final client for them so they can switch next week to a production ICD-10.
So Barry, when you say that they say it doesn't look any different, do you mean that it's a non-issue, this switch to ICD-10 because of your system making it so easy?
Yes, because as Tracy has explained, all our assessments, we move the assessment based on SNOMED and we link them and we map them to the ICD-10. So it is to start with the treatments. Basically, it's the same treatment they already have. And now, instead of being linked to ICD-9, they're already automatically linked to ICD-10. But as Chris has shown, they can intercede in any point, and they can elaborate or change the code if they wish to.
Okay, great. Super. Thanks. One question here maybe for Tracy and Chris. How can I add another ICD-10 code to an assessment if I need to?
Yeah, I actually demonstrated that in the little demo there, but I showed how you can just quickly, add additional codes if need be during the time of actually diagnosing the patient. It's easy to just click, see what's selected, and to also search for, the whole list of ICD-10 codes. I can click on the actual code and see the tree view and select from there, and I can add an additional code on the fly to bill along with whatever other codes I had with that original assessment as well.
Great, thanks for that. That was a great summary of it. Terrific. Here's another question, and we can just see who wants to jump in and answer this. If I don't see Medicare patients, will I have to use the ICD-10 codes?
I can answer to that. This is Kelly. Yes, you absolutely do have to use the ICD-10 codes. Everyone who's covered by HIPAA is going to have to use the ICD-10 code set starting October 1st. No one is immune, unfortunately.
Okay, darn. Another question would be is, do I have to learn the whole code set? And maybe this is one for you, Barry.
I think as we have demonstrated, when the doctors chart, we pretty much pick up the information in the background, the way we used to do with the ICD-9 and we're linking it to the ICD-10. But also, they do need to have some, obviously, more understanding of it because there are certain codes that we show that they may need to be more elaboration and more codes to be picked up, but we made that process even easy by adding the search and the tree views and make it very simple for them to do so. But if it gets even more complicated than that, obviously we got mScribe that can help them further along with more details and if they need so.
Okay,
and
great.
Dawn, I would like to elaborate on that a little bit.
Sure.
So what you will need, you won't need to know the whole every single code in entirety, but what you will need to study is your specific codes that you're going to use on a day-to-day basis that have, exclusions and things like that, and also rules that you must bill an additional code along with this one code. So the rules on those certain codes are what really need to be studied, and just like when we were demoing, when you go to assess somebody, if I know when I assess somebody with this that I also have to build this additional code, then I can quickly select that code as well. So the rules are really important, not really the codes themselves and memorizing the numbers and things like that and the actual structure of this code, but the rules that drive those.
Excellent. Thank you very much for that clarification. That was really helpful. So here's another question. What is the biggest change that ICD-10 will cause for providers? And I'm actually going to ask everybody to answer this. So why don't we start with Kelly first, and then we'll go to Tracy, Chris, and Barry. So what is the biggest change that ICD-10 will cause for providers?
Well, I think because ICD-10 codes are more specific than the ICD-9 codes, in order to accurately code a diagnosis, the more specific documentation, that's where it's going to fall. Many unspecified codes have been eliminated, so therefore the documentation processes that are currently used by providers are going to have to be revised to collect the appropriate information for ICD-10 diagnosis coding. So it's really all going to be in the documentation, and the providers are going to have to be as specific as possible when they are charting for their patients.
Okay, thank you, Kelly. Over to Tracy.
I think one of the biggest things they're going to have to do, like she said, is the documentation, and that's one good thing about using an EMR, is especially our EMR, is the ability to build in the questions that you need to make sure you answer on each visit, especially for your history of present illness and your review of systems. And those questions are built into our system, and if you answer the questions or use the EMR the way it's designed, and do a lot less free typing, a lot more of clicking instead of free typing, you will accomplish all of that, and you won't have an issue with the documentation. You'll have very good documentation. So it's going to be embracing your EMR and using it to its fullest extent.
Excellent. Thank you, Tracy. And over to you, Chris.
Yeah, I agree with the previous statements. Major thing is that non-specific code that providers are used to picking. You know, they memorize these codes because they've been using them for so long. They pick that non-specific code. They don't care about their well, some of them really don't care about the documentation. They just want to, send that over and get paid on it. Now you're not going to be able to do that. Another thing is getting used to seeing problems, in SNOMED and understanding that you are picking an assessment, but you are also having to link a billing code along with that assessment. And just, in previous, versions of our client and just with ICD-9, all they had to do was pick an ICD-9 code. That was the diagnosis, and that was, what went on all the screens. Now for interoperability and sharing information across multiple systems, that SNOMED, is very important for that reason, and they're just going to have to get used to seeing kind of the SNOMED descriptions and the ICD-10 descriptions and things like that.
And I think one of the reasons that we show both of them so prominently is so that the provider gets used to seeing both of them, and he becomes comfortable that he's picking the right codes and he is billing correctly, and his medical record has accurate information.
And Tracy, I know you talked a little bit about accurate information yesterday in a pre-discussion. Do you just want to elaborate on that a little bit more?
Well, that's one of the reasons we went with the SNOMED codes, because if you try to map ICD-10s back to SNOMED to put that so that you can send that information out electronically, there are so many variables in the SNOMED being mapped from ICD-10s, and so you could probably make a mistake or be inaccurate. So by picking the SNOMED code, the provider is actually picking what goes out in that electronic information, but he also sees what ICD-10 is being billed to the insurance company, so he knows both of those items are correct. He's not picking an ICD-10 code that maps back to a SNOMED code that's either not as specific as it should be, or it's because sometimes, in ICD-10 and ICD-9, you'll have this also includes, and you'll have 10 different things, and those 10 different things that are in the ICD-10 code may not be exactly what was in the SNOMED code that was mapped to it. So by picking the SNOMED code, he's picking the most specific thing that's on the list that's mapped to that ICD-10. I can't, off the top of my head, I can't think of a good example right now, but there are certain codes that you'll have one billing code for it, but the conditions that are associated with it may have different treatments.
Right.
May treat them in two different ways.
Great. Well, that's a great overview. Thank you very much, Tracy. So given that we're almost at the top of the hour and we've pretty much exhausted all of our questions, I'm just going to let Barry sort of do a recap, because Barry, you're very close to the customer, and I know you have conversations with many people as you've been going through this transition and getting ready for ICD-10. So maybe you can just highlight some feedback that you've received from some of your leading physicians who are using Excite Health, and tell us what they're saying right now as we get ready for this October 1st change.
It has been a grueling process that started a very long ago. Initially, we looked at all the solutions in the marketplace, and we thought about partnering with other solution providers who already built this solution. And every one of them that we looked at, none of them has been able to fit the easy-to-use part of the workflow configurable system that we have. So reluctantly, we went out and we built it ourselves from the ground up. And as you saw, and our customers have been attesting to it, that the solution is beautifully simple and easy for them to use. It's already in the same workflow and the same way they've already been doing for years. So the transition is really, really simple for them. As you can see, we took it upon ourselves to a large extent to pretty much do the coding for them as they go along through the chart. So our customers, when we started doing, when Chris was giving webinars and showing them the solution, before we even did some betas, they were like, wow, that's it? I mean, when you get wow, that's it, you know you're in the right track. So that has been the feedback from our customers with the beta testers and the webinars, that they think it's extremely simple, it's straightforward. We pretty much, they're doing the same thing like they used to do with ICD-9, but now when the day comes, there's a preference button that right now they're coding and everything goes to ICD-9, and the day they'll turn the switch, they'll get ICD-10 codes, and that's it. So simple. That's the feedback we got. Easy to use.
Great, thanks. And I'm sure that the fear in everybody's mind is loss of revenue or loss of productivity and lack of efficiency, and it sounds like we've got all that covered. So I just want to say thank you to all the speakers today. You've done a great job at laying out the landscape here, and I'm hoping to have lots more people learn about this seamless transition straight from the EHR into billing and into the revenue being a steady flow as it was before. So have a great day, everyone. Just a short reminder to complete the survey that's in the chat box and give us some feedback for future webinars. And we look forward to hearing more from Excite Health and mScribe and learning about the successes that people are having after this October 1st transition time. Thanks again. Take care.
Thank you very much for everybody for participating and helping. Thank you.